Welcome to this video entitled Liver Disease Case Studies. Let's begin with liver disease case studies. In this chapter, case studies levels 1 to 3 explore the management of a patient with alcoholic liver disease. The patient has alcoholic liver cirrhosis and first presents with alcohol withdrawal. Case study level 1. Then the patient's risk of bleeding and treatment for the maintenance of alcohol abstinence are considered. Case study level 2. The patient then goes on to develop encephalopathy. Case study level 3. Case studies levels MA and MB consider two patients. One presents with TB and the other liver failure. Next we will discuss case study level 1 involving alcoholic cirrhosis, alcohol withdrawal. Let's begin with learning outcomes. On completion of level 1 case study, you will be able to accomplish the following. 1. Describe the risk factors. 2. Describe the disease. 3. Describe the pharmacology of the drug. 4. Outline the formulation, including drug molecule, excipients, etc. for the medicines. And 5. Summarize basic social pharmacy issues, e.g. opening containers, large labels. Next we will discuss a clinical scenario. Mrs. M.W., 59 years old, is divorced and unemployed. She was admitted to an acute medical ward at the hospital presenting with general malaise, a grossly distended abdomen, swollen ankles and jaundice. It was also noted that she smelt of alcohol and was showing signs of alcohol withdrawal. Question 1 reads, what is cirrhosis of the liver? Cirrhosis is defined as the histological development of regenerative nodules surrounded by fibrous bands in response to chronic liver injury. It is an advanced stage of liver fibrosis that is accompanied by distortion of the hepatic vasculature. Question 2 reads, list possible causes of cirrhosis. Causes of cirrhosis can usually be identified by the patient's history combined with serological and histological investigation. Alcoholic liver disease and hepatitis C and B are the most common causes of cirrhosis. The association of excessive alcohol consumption with liver disease has been recognized for centuries. After the identification of the hepatitis C virus and of non-alcoholic steatohepatitis in obese patients with diabetes, the diagnosis of cirrhosis without an apparent cause, that is cryptogenic cirrhosis, is rarely made. Genetic causes of cirrhosis include hemochromatosis and Wilson's disease. Epidemiological studies have identified a number of factors that contribute to the risk of developing cirrhosis. Regular, moderate, alcohol consumption, age older than 50 years, and male gender are examples that increase cirrhosis risk in chronic hepatitis C infection, and older age, obesity, insulin resistance or type 2 diabetes mellitus, hypertension and hyperlipidemia in non-alcoholic steatohepatitis. Question 3 reads, what other clinical signs and symptoms may Mrs. M.W. present with? Cirrhosis is often asymptomatic until complications of liver disease are present. Mrs. M.W. may present with itching, jaundice, dark urine, pale fatty stools, abdominal pain, nausea, fatigue, bleeding, such as nosebleeds, hepatic encephalopathy, hepatomegaly, ascites, distended abdominal veins, spider angiomata, Palmar erythema and asterixis. She may also present with the signs and symptoms of alcohol withdrawal, which include irritability, anxiety, tachycardia, tremor, sweating, confusion and hallucination. Question 4 reads, what drug treatment, including dose, would you recommend for Mrs. M.W.'s alcohol withdrawal? What recommendations would you make if the patient was unable to take the medication orally? Long-acting benzodiazepines, e.g. diazepam and chlordiazepoxide, are used to attenuate alcohol withdrawal symptoms, but they also have a dependence potential. To minimize the risk of dependence, administration should be for a limited period only, e.g. chlordiazepocid 20 mg 4 times daily, gradually reducing to 0 over 7 to 14 days. Mild alcohol withdrawal symptoms may be treated with a lower starting dose, such as 15 mg 4 times a day. In all cases, the patient should be counseled about the proposed length of the treatment course. Benzodiazepines should not be prescribed if the patient is likely to continue drinking alcohol. In patients unable to take medication by the oral route, diazepam may be administered by intramuscular or slow intravenous injection into a large vein, at a rate of not more than 5 mg per minute, at a dose of 10 mg, repeated if necessary after not less than 4 hours. Alternatively, diazepam may be administered via the rectal route as a rectal solution or suppository. The intramuscular route should only be used when both the oral and intravenous routes are not possible. Next we will discuss case study level 2 involving alcoholic cirrhosis, management of bleeding risk and treatment for the maintenance of alcohol abstinence. Let's begin with learning outcomes. On completion of level 2 case study, you will be able to accomplish the following. 1. Interpret relevant lab and clinical data. 2. Identify monitoring and referral criteria. 3. Explain treatment choices. 4. Describe goals of therapy, including monitoring and the role of the pharmacist or clinician. And 5. Describe issues, e.g. counseling points, adverse drug reactions, drug interactions, complementary or alternative therapies and lifestyle advice. Next we will discuss a clinical scenario. Mrs. M.W., 59 years old, is divorced and unemployed. She was admitted to an acute medical ward at the hospital presenting with general malaise, a grossly distended abdomen, swollen ankles and jaundice. It was also noted that she smelt of alcohol and was showing signs of alcohol withdrawal. Mrs. M.W. weighs 61 kilograms, with the ascites, and her laboratory data are as follows. Total protein is 49 grams per liter. The reference range is 63 to 80 grams per liter. Albumin is 20 grams per liter. The reference range is 32 to 50 grams per liter. Total bilirubin is 114 micromoles per liter. The reference range is less than 17 micromoles per liter. ALP is 382 international units per liter. The reference range is 100 to 300 international units per liter. ALT is 88 international units per liter. The reference range is 5 to 42 international units per liter. INR is 1.6 GGT is 306 international units per liter. Less than 50 international units per liter. Diagnosis of alcoholic cirrhosis of the liver was made based on Mrs. M.W.'s clinical features, liver function tests, abdominal ultrasound, CT scan and liver biopsy. Question 1 reads, describe how Mrs. M.W.'s laboratory results relate to her diagnosis. Albumin is synthesized in the liver and has a long half-life of around 20 days. Mrs. M.W.'s low serum albumin is indicative of chronic liver disease. Albumin synthesis is also depressed in states of poor nutrition. Bilirubin is carried within the plasma by albumin to the liver, where it is conjugated by glucuronidation. Subsequently, low circulating albumin levels and/or damage to the liver cells result in reduced conjugation of the bilirubin. Blockage of the biliary tract, e.g. cholestasis, will result in increased levels of conjugated bilirubin. Bilirubin levels of more than 35 micromoles per liter can result in visual signs of jaundice. The concentration of both the unconjugated and conjugated bilirubin are likely to be raised in Mrs. M.W. However, only total bilirubin was measured in this case. Alkaline phosphatase, abbreviated as ALP, is present in high concentrations in the cells lining the biliary tract, and an alkaline phosphatase level exceeding 300 international units per liter, together with a raised bilirubin as in the case of Mrs. M.W., is indicative of cholestasis. Jaundice becomes progressively more severe in unrelieved cholestasis. Alanine aminotransferase, abbreviated as ALT, is present in high concentrations in the liver, and the enzyme is released during hepatocellular damage, and a modestly raised level like Mrs. M.W.'s is indicative of chronic liver disease. The increased susceptibility to bleeding observed in patients with liver failure, raised INR, results from depressed fibrinogen levels and the reduced synthesis of clotting factors by the cirrhotic liver. In addition, the absorption of fat-soluble vitamin K is impaired in cholestasis, and subsequently the synthesis of vitamin K-dependent clotting factors is reduced. Gamma-glutamyl transferase, abbreviated as GGT, is found in the liver, but this test is relatively nonspecific. It is released following tissue damage and is raised in cholestasis in parallel with ALP. Gamma-glutamyl transferase release is stimulated by alcohol and some drugs, such as phenytoin and carbamazepine, and therefore the gamma-glutamyl transferase level can be used to assess abstinence in alcoholics, like Mrs. M.W. Question 2 reads, what treatment would you recommend to reduce her risk of bleeding? Mrs. M.W. has a raised INR value of 1.6 and is therefore at increased risk of bleeding. Vitamin K can be given to correct the vitamin deficiency, either as an intravenous injection or orally. Quinaqion MM is phytomenadione, 10 mg per milliliter, in a mixed micelles vehicle. Quinaqion MM may be administered by slow intravenous injection or by infusion in glucose 5%. For oral administration, the water-soluble preparation Menadiol sodium phosphate is used in patients with hepatic disease, especially biliary obstruction. The usual dose is 10 mg daily. Alternatively, phytomenadione tablets may be used in those patients who do not have impaired fat absorption. If vitamin K is ineffective in controlling the clotting times, monitored via the INR result, then fresh frozen plasma may be required. Question 3 reads, what medications would you advise Mrs. M.W. to avoid in view of her bleeding risk? Medications known to increase the risk of bleeding in cirrhotic patients include aspirin, clopidogrel, dipyridamole, corticosteroids, non-steroidal anti-inflammatory drugs, heparin and warfarin. Mrs. M.W. would need to be counseled about the risks associated with these medications and advised to always check with the pharmacist before buying any medications over the counter. Question 4 reads, what treatment options are available to help Mrs. M.W. abstain from alcohol in the future? Disulfiram is an aversive therapy that works by inhibiting acetaldehyde dehydrogenase. Interactions between disulfiram and alcohol can result in potentially severe reactions, such as myocardial infarction, congestive heart failure, respiratory depression and death. Patients taking disulfiram should be warned of the possible presence of alcohol in liquid medicines, tonics, foods and even in toiletries and mouthwashes. Patient adherence to disulfiram is poor and there is a lack of strong evidence for its effectiveness, thus it is not routinely recommended. Acamprosate is indicated for the maintenance of abstinence in alcohol-dependent adults. It appears to decrease brain hyper-excitability during alcohol withdrawal, which may reduce alcohol consumption. Treatment should be initiated as soon as possible after the alcohol withdrawal period is complete. The recommended period of treatment with acamprosate is 1 year and treatment should be combined with counseling. The GGT level can be monitored as a marker of abstinence from alcohol. Next we will discuss case study level 3 involving hepatic encephalopathy and ascites. Let's begin with learning outcomes. On completion of Level 3 case study, you will be able to accomplish the following. 1. Interpret clinical signs and symptoms. 2. Evaluate laboratory data. 3. Evaluate treatment options. 4. State goals of therapy. 5. Describe a pharmaceutical care plan to include advice to a clinician. 6. Describe the prognosis and long-term complications. And 7. Describe the social pharmacy issues which could include supply, e.g. complex treatments at home, concordance and compliance, and lifestyle issues. Next we will discuss a clinical scenario. Mrs. M.W., 59 years old, is divorced and unemployed. She was admitted to an acute medical ward at the hospital presenting with general malaise, a grossly distended abdomen, swollen ankles and jaundice. It was also noted that she smelt of alcohol and was showing signs of alcohol withdrawal. On examination, Mrs. M.W. was found to be encephalopathic. The doctors decided to treat her encephalopathy and ascites. Question 1 reads, what is hepatic encephalopathy? What are the clinical signs and symptoms? Hepatic encephalopathy is a neuropsychiatric syndrome which may complicate almost all types of liver disease. It may occur intermittently and be reversible or may occur acutely, with rapid progression to coma and death. Mrs. M.W. presented with signs of hepatic encephalopathy including flapping tremor of the hands, intellectual deterioration, slurred speech, confusion, drowsiness and irritability. Question 2 reads, what factors may precipitate hepatic encephalopathy? Factors that may precipitate hepatic encephalopathy include the following. 1. Hyperkalemia and/or profound diuresis caused by a brisk response to a potent diuretic. 2. Diarrhea and vomiting. because of the resulting fluid and electrolyte imbalance. 3. Constipation. 4. A large protein meal or gastrointestinal hemorrhage. 5. Infection, especially peritonitis. And 6. CNS depressant drugs, such as opioids or benzodiazepines. Question 3 reads, list 2 treatment options for the management of Mrs. M.W.'s hepatic encephalopathy. Describe the mechanism of action for one of these. Treatment goals for hepatic encephalopathy include provision of supportive care, identification and removal of precipitating factors, reduction in the nitrogenous load from the gut, and optimization of long-term therapy. Therapy should be directed toward improving mental status via bowel cleansing with lactulose or with enemas. The dose of lactulose should be titrated to give 2 soft stools per day without diarrhea. Lactulose is metabolized in the colon to lactic, acetic and formic acids, causing the pH of the colon to drop from 7 to 5. Colonic acidification with lactulose alters the bacterial population and favors the growth of weak ammonia-producing bacteria rather than proteolytic ammonia producers such as Escherichia coli. In addition, the drop in colon pH leads to ionization of nitrogenous products with a subsequent reduction in their absorption from the gastrointestinal tract into the blood. Third, the osmotic laxative effect speeds the intestinal transit, thereby decreasing the time available for the absorption of potentially toxic nitrogen compounds. It is imperative to monitor Mrs. M.W.'s bowel frequency while treating with lactulose since fluid and electrolyte imbalances secondary to diarrhea may precipitate hepatic encephalopathy. Mrs. M.W.'s mental test score should also be repeated to assess benefit. Neomycin, dosed at 4 grams daily in divided doses, is a non-absorbable antibiotic which may be used to reduce the number of bacteria in the bowel that normally break down protein. Neomycin therapy is usually limited to 1 week's therapy because some absorption may occur with a risk of nephrotoxicity and ototoxicity. Question 4 reads, what factors are likely to have contributed to the development of ascites in Mrs. M.W.? Mrs. M.W. presented with a swollen abdomen, swollen ankles, pitting edema and breathlessness. There are 2 key factors involved in the pathogenesis of ascites formation, namely, sodium and water retention and portal hypertension. The development of renal vasoconstriction in cirrhosis is partly a homeostatic response involving increased renal sympathetic activity and activation of the renin-angiotensin system to maintain blood pressure during systemic vasodilatation. Decreased renal blood flow decreases glomerular filtration rate and thus the delivery and fractional excretion of sodium. Cirrhosis is associated with enhanced reabsorption of sodium, both at the proximal tubule and at the distal tubule. Increased reabsorption of sodium in the distal tubule is due to the increased circulating concentrations of aldosterone, occurring secondary to the reduced hepatic metabolism of aldosterone. However, some patients with ascites have normal plasma concentrations of aldosterone, leading to the suggestion that sodium reabsorption in the distal tubule may be related to enhanced renal sensitivity to aldosterone. In compensated cirrhosis, sodium retention can occur in the absence of vasodilatation and effective hypovolemia. Sinusoidal portal hypertension can reduce renal blood flow even in the absence of hemodynamic changes in the systemic circulation, suggesting the existence of a hepatorenal reflex. Portal hypertension increases the hydrostatic pressure within the hepatic sinusoids and favors transudation of fluid into the peritoneal cavity. Systemic vasodilatation, the severity of liver disease and portal pressure contribute to the abnormalities of sodium handling in cirrhosis. Question 5 reads, name 2 treatment options for the management of Mrs. M.W.'s ascites. Describe the pharmacology of these therapies, including any potential side effects. What would you monitor in order to determine whether the therapy was effective? Management of ascites aims to mobilize ascitic fluid, relieve abdominal discomfort and breathlessness and to exclude infection. Diuretics have been the mainstay of treatment of ascites since the 1940s when they first became available. Spironolactone, an aldosterone antagonist, is the drug of choice since secondary hyperaldosteronism often coexists in patients with hepatic ascites. Aldosterone is usually metabolized by the liver and is highly protein-bound. Therefore the free aldosterone levels are raised in cirrhosis. Spironolactone competes with aldosterone for receptor sites in the distal tubule, resulting in potassium retention and sodium and water loss. The initial dose of spironolactone is 100 to 200 mg and can be slowly increased according to response. There is a lag of 3 to 5 days between the beginning of spironolactone treatment and the onset of the natriuretic effect. The aim is to remove the fluid gradually with a maximum weight loss of 0.5 kg per day in the absence of peripheral edema, or 1 kg per day if peripheral edema is present. Too rapid a diuresis will result in intravascular fluid loss rather than the peripheral edema. The diuretic should be stopped if the serum sodium falls below 120 mmol per liter or if there is a rising serum creatinine. Urinary electrolytes should be monitored to ensure that the spironolactone therapy is effective. The aim is to reverse the sodium to potassium ratio in the urine so that more sodium than potassium is excreted. Most frequent side effects of spironolactone are those related to its anti-androgenic activity, such as decreased libido, impotence and gynecomastia in men and menstrual irregularities in women. Other side effects include hypokalemia, uremia, hyponatremia and nausea. In addition to spironolactone, ascites can be managed by paracentesis. That is the removal, tapping, of ascitic fluid from the peritoneal cavity under aseptic conditions. A colloid, human albumin solution, 20%, is infused, 40 ml, that is 8 grams of albumin, per liter of ascites drained, intravenously during paracentesis, in order to prevent intravascular volume depletion and the onset of renal failure. Following paracentesis, ascites recurs in the majority, that is 93%, if diuretic therapy is not reinstituted, but recurs in only 18% of patients treated with spironolactone. Cirrhotic ascites can become infected, and if peritonitis occurs, survival depends on early, vigorous antibiotic therapy. The patient should be monitored for signs of infection. Next we will discuss case study level MR involving pulmonary tuberculosis. Let's begin with learning outcomes. On completion of level M case study, you will be able to accomplish the following. 1. Interpret clinical signs and symptoms. 2. Evaluate laboratory data. 3. Critically appraise treatment options. 4. State goals of therapy. 5. Describe a pharmaceutical care plan to include advice to a clinician. 6. Describe the prognosis and long-term complications. 7. Describe social pharmacy issues which could include supply, e.g. complex treatments at home, concordance and compliance, and lifestyle issues, and 8. Describe the monitoring of therapy. Next we will discuss a clinical scenario. J. S., a 46-year-old male patient, returned from India with cough, malaise, weight loss and night sweats. Sputum culture showed acid-fast bacilli and 3 days later Mycobacterium tuberculosis was isolated. Question 1 reads, what is TB? What causes it and what is the most common source of infection? Tuberculosis, TB, is an infection with Mycobacterium causing the presence of tubercles. The most common single source of infection is the lungs. If the tubercles are within the blood and more than 2 tissue sites, e.g. lungs and liver, then it is called miliary tuberculosis. Tuberculosis is caused by Mycobacterium tuberculosis or more rarely Mycobacterium bovis. Infection spreads by inhalation of infected droplets. Question 2 reads, how does it present in the UK? The most common presentation is in people returning from holiday in Asia or Africa. It is also seen in immunocompromised patients, oncology, HIV patients, and IV drug abusers, and those living on the streets or in cramped accommodation. Steroids can reactivate dormant tubercles, so it may present after a course of corticosteroids. Question 3 reads, what drugs could be used to treat it and what makes resistance likely? The drugs used to treat TB include capreomycin, cycloserine, ethambutol, isoniazid, pyrazinamide, rifabutin, rifampicin and streptomycin. Resistance is most likely with long courses of treatment of antimicrobial agents, and treatment courses are 6, or even 9, months long. This patient was commenced on triple therapy with rifampicin 600 mg daily, isoniazid 300 mg daily and streptomycin 750 mg daily. All 3 agents are bactericidal against fast-growing extracellular bacilli, so they produce rapid sterilization of sputum to decrease spread. Rifampicin is also active against dormant intracellular organisms that undergo phases of rapid growth. The patient was already taking carbamazepine 200 mg twice daily throughout admission for epilepsy. Question 4 reads, are there any problems with this? And how might they be managed? Isoniazid can cause convulsions and therefore should be prescribed with caution in patients with epilepsy. Isoniazid is an enzyme inhibitor and may increase carbamazepine levels. Rifampicin is an enzyme inducer and may decrease carbamazepine levels. Question 5 reads, J. S. received only 750 mg daily of streptomycin. Why was this reduced and how should it be monitored? This dose is used in patients over 40 years of age if they have subclinical renal failure. Streptomycin is an aminoglycoside, so is associated with oto and nephrotoxicity. Monitoring is by blood levels with peak 1 hour post-dose below 40 mg per liter and trough below 3 mg per liter. 3 weeks later he was admitted to hospital complaining of increasing malaise, muscular aches, nausea, decreased appetite, shortness of breath, cough and fever. He was jaundiced with hepatomegaly, blood pressure 120 systolic 70 diastolic, pulse 76 beats per minute, regular. Chest X-ray showed a right pleural effusion and biochemistry showed increased bilirubin, ALP, ALT and AST. Albumin was low. Question 6 reads, what is likely to be causing these signs and symptoms? Rifampicin can cause renal failure, transient disturbances of liver function tests, hyperbilirubinemia or severe hepatotoxicity and other side effects. Streptomycin can cause renal and ototoxicity. The combination of rifampicin and streptomycin increases the risk of streptomycin-induced renal failure. Isoniazid-induced hepatitis has an incidence estimated at 0.1%, but is higher in fast acetylators. Rifampicin is an enzyme inducer and can increase the incidence and severity of isoniazid-induced hepatitis. Carbamazepine is an enzyme induction agent and interacts with isoniazid, increasing its hepatotoxicity. Isoniazid toxicity is associated with fast acetylator genotype. Although his phenotype was unknown, the interaction with carbamazepine increases risk of this toxicity. Isoniazid is an enzyme inhibitor and may increase carbamazepine levels, so this was checked. Carbamazepine levels were checked and normal at 16 micromoles per liter, corresponding to 17 to 50 micromoles per liter. J.S. was diagnosed as having drug-induced hepatitis and all anti-TB medication was stopped. Question 7 reads, what can be done to reduce drug-related toxicity? One. Various detoxifying products have been tried with variable success. 2. If severe, the medication should be stopped. This stops the input of substrate, reduces the drive to speed up, that is increase quantity, of metabolic enzymes and reduces the generation of toxic metabolites. 3. Thiamine is given for alcohol-induced liver toxicity, to prevent Wernicke's encephalopathy. 4. Pyridoxine was commenced to prevent any isoniazid-induced peripheral neuropathy, particularly as the patient was a vegetarian of Asian ethnicity and prone to this vitamin deficiency. 5. Vitamin C and E are given to provide antioxidants and reduce oxygen-free radicals. 6. Acetylcysteine is given as a glutathione precursor in paracetamol overdose and in many other liver failures, including septic shock. Question 8 reads, with reference to the biochemistry results. A. What is the significance of the raised INR on day 19 of admission? B. What is the significance of the raised ESR on day 23? C. Why is the white count stable at 4.7 to 7.3? D. Compare the profile of bilirubin, gamma-GT, ALT and ALP. 1. An abnormal INR is the fastest indicator of altered liver function. Clotting relies on both the synthesis of clotting factors and then their activation as required. A raised INR shows that liver synthetic function may have slowed or stopped. 2. A raised ESR indicates an inflammatory process in progress. Immunoglobulins stick to the red blood cells, causing them to settle out of solution at a faster rate. 3. The infection appears to be being treated. hence white blood cells are only required to finish off and clear the wounded bacteria. In a viral infection, a huge white blood cell response may be required with cytokines to kill the viral particles. 4. GGT shows the most significant change, with peaks 5.5 times baseline, but it is not a routine test. 5. Bilirubin is triggered in line with INR and rapidly shows that red blood cells are being destroyed. Its peak-to-baseline ratio is similar to that of GGT. It starts to fall relatively quickly and it is a routine test. 6. ALT gives an early signal of hepatocellular damage, but with a peak-to-baseline ratio of less than 4, it falls slower than bilirubin. 7. ALP rises relatively early and settles very late, but the peak-to-baseline ratio is less than 2. This is because it shows sludging of the bile duct as a secondary event to the hepatocellular damage. A week after stopping the anti-TB drugs, his liver function tests had settled and isoniazid was reintroduced at 150 mg dose, after 3 days increased to 300 mg daily. Rifampicin was then started initially at 300 mg, then increased to 600 mg daily. 3 weeks into the admission, streptomycin was recommenced, and 4 days after commencing, streptomycin levels were checked and found to be trough, below 1 mg per liter, peak, 23 mg per liter. Target peak, below 40 mg per liter, trough, below 3 mg per liter. Note: rifampicin can increase risk of streptomycin-induced renal dysfunction. A week later he went home on full anti-tuberculosis drugs with stable liver function tests and carbamazepine and the addition of pyridoxine. The white count does not suggest resistance has emerged during this treatment gap, but should be monitored over the full treatment course. Any acute liver insult on top of this treatment would be very difficult to resolve. Compliance with the pyridoxine is very important to prevent any toxicity. Next we will discuss case study level MB involving liver failure. Let's begin with learning outcomes. On completion of level M case study, you will be able to accomplish the following. 1. Interpret clinical signs and symptoms. 2. Evaluate laboratory data. 3. Critically appraise treatment options. 4. State goals of therapy. 5. Describe a pharmaceutical care plan to include advice to a clinician. 6. Describe the prognosis and long-term complications. 7. Describe the social pharmacy issues which could include supply, e.g. complex treatments at home, concordance and compliance, and lifestyle issues. And 8. Describe the monitoring of therapy. Next we will discuss a clinical scenario. A 43-year-old woman was admitted to hospital in December feeling unwell with a 2-week history of urinary symptoms. She had decompensated cirrhosis of her liver on ultrasound and was taking pentoxaphylline, marketed as oxpentophylline, or Trental, coamoxiclav, omeprazole and thiamine. She was jaundiced and confused with respiratory failure limiting speech to partial sentences. There was a marked deterioration in liver function overnight and she went into acute renal failure. The hepatic team managed her care for 5 days because she was known to consume 1 liter vodka per day. Cultures from urine grew Escherichia coli and sepsis from this was presumed. On the medical ward she was self-ventilating with oxygen saturations of 90% on 4 liters per minute oxygen. Her respiration rate was 25 per minute and she was unable to speak. Her blood pressure was 98 systolic 60 diastolic, pulse 120 beats per minute. She was admitted to intensive care with type 1 respiratory failure, low oxygen. She had rising lactate, chest sepsis and worsening liver function tests and raised INR. Her laboratory results are WCC 11 × 10⁻⁹ per liter. The reference range is 4 to 11 × 10⁻⁹ per liter. INR is 1.6. The reference range is 0.8 to 1.2. APTR is 0.9. The reference range is 0.8 to 1.2. Sodium levels of 125 millimoles per liter. The reference range is 135 to 145 millimoles per liter. Potassium levels of 2.8 millimoles per liter. The reference range is 3.5 to 5 millimoles per liter. Urea of 18 millimoles per liter. The reference range is 3 to 6.5 millimoles per liter. Creatinine 174 micromoles per liter. The reference range is 60 to 125 micromoles per liter. Amylase 315 international units per liter. The reference range is 36 to 126 international units per liter. Bilirubin 113 micromoles per liter. The reference range is less than 20 micromoles per liter. Alkaline phosphatase, abbreviated as ALP, is 131 international units per liter. The reference range is 100 to 300 international units per liter. Alanine phosphatase, abbreviated as ALT, is 53 international units per liter. The reference range is 5 to 42 international units per liter. She had good cardiac output with a raised heart rate, that is 109 beats per minute, and central venous pressure of 18 mm of mercury with bilateral wheeze and fluid overload. The family were told she had a 50-50 chance of survival. She was given vancomycin infusion, tazocin and terlipressin. The raised amylase suggests acute alcohol-induced pancreatitis. The patient was developing hepatorenal syndrome with hyponatremia, a coagulopathy, and was agitated. The lactate continued to rise to 8, urea 89, creatinine 158, and urine output fell to below 30 ml per hour. The next day the patient had decreased respiratory rate, became tired with falling blood sugar and acidosis. She had acute renal failure with urine output less than 30 ml per hour and was in fluid overload. The doctors started her on terlipressin 2 mg 4 times daily and HAS, human albumin solution, 20% to maintain central venous pressure 8 to 12 mm of mercury and prevent hepatorenal syndrome. Terlipressin is a prodrug for vasopressin. Question 1 reads, just before intensive care unit admission this patient has a low blood pressure and a high heart rate. What is the most likely cause of this? Peripheral vasodilatation or a loss of blood volume will reduce systemic blood pressure. The heart tries to compensate and maintain cardiac output by increasing the heart rate. Sepsis causes vasodilatation and reflex tachycardia. Question 2 reads, how can you link sepsis and liver failure with a high lactate? Lactate is a byproduct of carbohydrate metabolism. It is burnt in the Krebs cycle normally, but when there is an insufficiency of oxygen, the normal production of carbon dioxide from glucose is not possible. Vasodilatation is a consequence of sepsis and produces abnormal blood flows, especially to the liver. So the liver does not metabolize glucose properly and lactate and acid are produced. Sepsis causes hypoxia and abnormal liver blood flow. The liver normally clears lactate. Question 3 reads, what is the usual cause of raised serum sodium? Serum sodium usually rises due to excess salt intake or dehydration. Question 4 reads, why does sodium rise and potassium fall in liver failure? The reverse happens in hepatorenal syndrome. Why? Aldosterone retains sodium in exchange for secreting potassium into the renal tubular fluid. Serum potassium therefore falls. In liver failure, aldosterone is not metabolized, so it accumulates. Therefore, in liver failure, serum sodium will rise and potassium fall. Question 5 reads, what is hepatorenal syndrome and how does liver failure worsen renal function? The liver metabolizes nutrients and toxins. The waste products overall are vasodilators, and they are usually converted by the liver into water-soluble compounds that can be excreted by the kidneys. In the failing liver, the metabolites are not eliminated and a net vasodilatation occurs. The major capillary beds are in the lungs and legs and skin. Thus the metabolites divert blood away from the kidneys. Question 6 reads, why does hepatic dysfunction make infection more likely? The spleen stores white blood cells and the liver produces the antibodies for infection. A lack of albumin causes tissue edema. When the gut becomes edematous, bacteria can translocate from the gut lumen into the bloodstream. Question 7 reads, the respiratory failure may be due to pulmonary edema. Why does liver failure produce edema? The liver does not synthesize enough albumin and does not metabolize aldosterone. A lack of albumin in the vascular space reduces colloid-oncotic pressure and water flows out of the blood vessels to form tissue edema or ascites, edema in the peritoneal cavity. Water oozing from the pulmonary arteries causes pulmonary edema. Question 8 reads, terlipressin is a prodrug for vasopressin. What does it do? Terlipressin is the lysine ester of vasopressin. Vasopressin is a vascular constrictor, particularly in the portal vein. It prevents esophageal varices from enlarging by decreasing portal vein blood flow. It also counteracts peripheral vasodilatation and generally diverts blood flow back to the kidneys. Next we will discuss sinusitis. Sinusitis is an inflammation and/or infection of the paranasal sinus mucosa. The term rhinosinusitis is used by some specialists because sinusitis typically also involves the nasal mucosa. The majority of these infections are viral in origin, nevertheless, antimicrobials are prescribed frequently. It is thus important to differentiate between viral and bacterial sinusitis to aid in optimizing treatment decisions. Viral sinusitis and bacterial sinusitis are difficult to differentiate because the clinical presentations are similar. Viral infections, however, tend to resolve by 7 to 10 days. Persistence of symptoms beyond this time likely indicates a bacterial infection. Bacterial sinusitis can be categorized into acute and chronic disease. Acute disease lasts less than 30 days with complete resolution of symptoms. Chronic sinusitis is defined as episodes of inflammation lasting more than 3 months with persistence of respiratory symptoms. Sinusitis is diagnosed more frequently in children than in adults. Typical clinical presentation and diagnosis of bacterial sinusitis are illustrated in Table 107-4. Between 5% and 13% of viral upper respiratory tract infections in children are complicated by bacterial sinusitis, whereas only 0.5% to 2% of viral upper respiratory tract infections in adults are complicated by sinusitis. Factors associated with the development of bacterial sinusitis include viral respiratory tract infections and, less commonly, allergic inflammation. Other factors that can be associated with sinus disease include systemic diseases, trauma, environmental exposures, and anatomic abnormalities.